We can say that in general there are two different types of treatments or ways of preparing a cryotransfer. The most usual one is to work with hormones, oral hormones, the hormonal replacement therapy that involves taking oral pills from day 1 of your cycle, have a scan done on day 8 to 10 of the cycle, and if the thickness of the endometrium and the pattern is okay, then decide when do you want to start progesterone to carry out the embryo transfer. That's probably the easiest way of preparing the embryo transfer, because it allows the patients to even decide when is better for them, and in this sense, when there are logistic issues, it's really helpful. The drawback is that if the patient gets pregnant, she must continue with the treatment until the placenta takes over the ovaries, something that happens around week 11. So patients must continue with the oral pills of estrogens, with the vaginal pessaries, because these treatments prevents them from ovulating, so they are not going to produce any hormones at all. So we must support the pregnancy until the hormones that come from the placenta start working. The other protocol is the so-called natural cycle, in which we basically monitor how the follicle grows during the cycle. And once this follicle reaches like 17, 18 millimeters, then we trigger the ovulation. And we usually trigger the ovulation first because it's easier than not doing LH tests that should be done every 4 hours to try to detect the LH peak, but also because it helps us to decide when the transfer is going to be done. If you take that injection for triggering the ovulation, you are going to ovulate 36 to 40 hours later, and we know that 5 days after that day, the transfer can be scheduled. In this kind of treatments, the patients usually need some progesterone, not at the same dose that if they are doing an hormone replacement therapy. And the good thing is that if they get pregnant, they must continue for progesterone, but they don't need to take it until the placenta takes over the ovaries. So usually after week 8 or something like that, when we see that there is an embryo with a heartbeat, they can stop the progesterone and continue as if it was a normal pregnancy. In terms of results, the same. The big studies confirm that the pregnancy rates are very similar. It's true that there are some studies that suggest that the miscarriage rate could be slightly lower if you work with a natural cycle, but we do not recommend any special treatment. It's true that if the patient has had or has done 2 cycles of hormone replacement therapy and she has not got pregnant, we may change and try with the natural cycle, or vice versa. If they have been on natural cycles and we don't get a success, we may change, because there are things that may be out of control that may make slightly differences between hormones and natural cycle. But at the beginning, we just leave it up to the patients to decide, depending on their schedule and what they do prefer, if they want to take hormones or going for the natural cycle.